Welcome, everyone. Thank you so much for joining us today as we dig into everything that comes with navigating steroid choices. We're in a really unique time in Duchenne where we're seeing the loss of exclusivity of Emflaza with potential access to generics. We have a new approval in Agamree, also known as vamorolone, and we recognize that there are a lot of questions and uncertainties that come with making a choice regarding a steroid regimen or potentially changing that steroid regimen. So we're really happy to be joined today by the team from University of Iowa. We have Dr. Kathy Mathews, who is their clinic director and a neuromuscular neurologist, Christina Trout, who is the clinic coordinator and a master's prepared nurse, and Rachel Kinn, who is a pharmacist who works with the clinic as well. And we're really excited because with this team, we're going to walk through the steroid process from beginning to end, having that conversation with your physician, making the right choice for the most appropriate medication, and then how you access that medication and what some of those implications might be with specialty pharmacies, generic versus brand, and all of these different pieces. So with that, we'll go ahead and dive in, and I will hand things over to Dr. Kathy Mathews. Dr. Mathews, go right ahead.
Thank you, Rachel. So I'm going to start out, and I'm going to talk kind of fast because I want to make sure that I leave time for my colleagues who understand the process and pathways and policies that are super important. So we are not forwarding. There we go. We all have some disclosures. I don't think we have any disclosures that will impact our the content of what we're going to present today. So steroids, I'm going to just do an overview of steroids. And there are other sources of information, other PPMD webinars that go into detail, so I'm going to be pretty quick about this. Take-home message, steroids are effective. I have one graph up here, but I could show you lots and lots of graphs from other papers showing that loss of ambulation is faster in people who are untreated than it is with people on steroids. Steroids are effective. They delay loss of ambulation, they delay scoliosis, they delay need for respiratory support, and they have other benefits. However, as I think everybody on this phone call or this webinar knows, steroids have significant side effects. They have weight gain, irritability, behavior problems, growth suppression, cataracts, delayed puberty, adrenal suppression, hypertension, and other things that I haven't listed. So we are in a difficult time because we always, when we have a new diagnosis, we want to do the thing that we know is beneficial, and we have abundant proof that they are beneficial, but we have side effects that we want to minimize, and we have to make decisions with incomplete data. And I'm going to talk to you a little bit about that incomplete data today. So I'm going to review a little bit of the data and options, like I said, very quickly, because I want to give the other speakers time. So the kinds of decisions that we have to make: what medicine, what dosing regimen, is it daily or intermittent? When do you start the corticosteroids, and should you switch? I'm not going to address all of these today. That would be a full hour webinar. We don't have time for that. But I'm going to, one of the take homes that I'm going to tell you is that you need to discuss the steroid options and all of these questions regularly with your neuromuscular team. So deflazacort, it's a corticosteroid that's been used for many, many years in Canada and Europe before it was ever approved by the FDA in 2017. And so we have an abundance of published literature on the use of deflazacort, probably decades now. Rachel is going to talk more about the generic potential versus brand name deflazacort. I will mention that the data from the European work and Canadian work was pre-brand name. So deflazacort was deflazacort. There is some evidence, and I'm going to show you two slides, to suggest that daily deflazacort is more effective than daily prednisone. The studies that suggest this are ones that are natural history studies, or in this case, looking at placebo arms of clinical trials, so they aren't head-to-head comparisons. So this was a post-hoc analysis looking at placebo arms, and the across outcome measures, deflazacort was favored. This is another older study that was natural history data, favors deflazacort. There was a very large recently published trial to try to answer this question of what is the best steroid regimen, and the options that they studied, it was started a number of years ago. COVID slowed things down, but it started a number of years ago to sort of nail this down because we were working with incomplete data. They compared daily prednisone, daily deflazacort, and a European protocol of 10 days on, 10 days off of prednisone. The bottom line is that any steroid is better than no steroid. Daily steroid is better than intermittent steroid with the 10 days on, 10 days off regimen, but there was no difference in outcome between deflazacort and prednisone. So when we look at some natural history kinds of things, maybe deflazacort's better. When they did the 4DMD trial, daily deflazacort and daily prednisone were equally effective. And then what did they learn about side effects? So daily prednisone, in terms of weight gain, daily prednisone was worse than daily deflazacort, which was worse than the 10 days on, 10 days off regimen. Deflazacort has been shown in a number of studies to have earlier cataracts, often needing surgery as early as teenage years, and greater growth suppression than prednisone. So I'm going to talk for a second about high-dose weekend prednisone, which was popularized by my colleague Ann Connolly, who is now at Nationwide Children's Hospital. This regimen is supported by some animal data, and it's different than that 10 days on, 10 days off study. So this is very high-dose prednisone, Saturday, Sunday, Friday, Saturday, 2 days a week. So in one of the earliest studies, they looked at 64 boys. It was a randomized placebo-controlled or a randomized trial comparing high-dose weekend to daily prednisone. And they showed equivalence in effectiveness between those two regimens. The linear growth, so height and bone density, were less affected on the weekend dosing than the daily prednisone. So you spared height and spared bone density with the weekend dosing, but there was no significant difference in body mass index or weight for height. You're going to hear that again when I talk about vamorolone. And the Synergy group also looked at using high-dose weekend prednisolone in children with Duchenne who were less than 3 years old. And they again showed treatment effect, even in these very young boys. Length was not suppressed, so they did not suppress growth with high-dose weekend, but there was some problem with weight gain for some boys, less with other boys. So high-dose weekend steroids prednisone is an option. And then vamorolone was just FDA approved in November 2023. It's expected to be clinically available in early 2024. I don't know anything more specific than that. And it's a novel corticosteroid that was specifically designed for Duchenne to decrease some of the side effects that we know that we see with daily deflazacort or daily prednisone. So the big trial that led to FDA approval looked at, had 4 different arms. There was vamorolone 2 milligrams a day, or 2 milligrams per kilogram per day, vamorolone 6 milligrams per kilogram per day, I missed a per kilogram there, I'm sorry, versus placebo, no steroid, versus daily prednisone. And it was a 24-week trial, so not even a year. What they found is that all the steroid treatments are effective and better than placebo. I'm sort of a broken record here. Height was spared in the vamorolone groups. It increased in the vamorolone groups, decreased in the prednisone group. The serum measures of bone density were improved in the vamorolone group. Lean body mass was better in the vamorolone group. The weight for height, BMI, was the same across all groups, and adrenal suppression was the same across all groups. So sort of a quick summary, and this is from another paper showing that the height percentile went up on the vamorolone group and down in the natural history group here. This isn't the trial, this is from natural history. So with vamorolone, we have no long-term data. We don't have 15 years of experience like we do with prednisone and deflazacort. Based on the available evidence and the biological properties, it spares height and there's less drug-related osteoporosis. There would still be Duchenne-related osteoporosis. And there's some additional evidence that it may have some cardioprotective effect, but we don't have any data in humans on that. So that's sort of my overview of our options. So there are a lot of factors that your healthcare team and parents take into effect when thinking about steroid dosing. Effectiveness, they work. Steroids are good. But the side effects really determine our choices to a large degree. For the newly diagnosed patient, we wonder about which side effect is of the greatest concern to the family and the patient. Different people have different things that they're most worried about. Obesity, height, what's the most concerning? For the older child or the adult patient, we're going to consider, what are you currently on? How are you doing on it? How are we already treating side effects? What's your current stage of motor function? And it's a discussion. What is the best option for me now? And then there are insurance restrictions and out-of-pocket costs to consider, and that's what my colleagues are going to discuss in great detail. So I throw this up there. I'm going to tell you that I change the pluses and the number of pluses or zeros on a regular basis. You'll see that I have a lot of question marks. This is my way of thinking about the steroids for Duchenne. And it looks at some of the common side effects, cost, and then how much data do we have? And just to point out a couple of things, I noted that we just don't have a ton of data on weekend prednisone and daily vamorolone. We have some, but we have more on weekend prednisone, probably even less on daily vamorolone. We don't have any long-term data on it. So I've got a lot of questions on this column. In general, side effects are less with weekend prednisone and daily vamorolone. The side effect profile for prednisone and deflazacort differs somewhat. The cost, I put a question mark in here because if generic deflazacort becomes available, we expect it to be less expensive. Right now, Emflaza is quite expensive and would be in the 2 to 3 pluses, but we don't know what's going to happen in the future. So my take-home points: there is not one best steroid choice that applies to every situation. This is something that you discuss with your physician. The patient is not locked into one regimen for life, but we also don't want you making switches back and forth. That's not good for you, not good, and it's dangerous. So you make your choice based on the best evidence you have. Be kind to yourself. We're working with incomplete information, so there is not a perfect answer, and people agonize, but there's not a perfect answer. Revisit that choice depending on side effects. Are things going differently? Do we have new information? So you've done that, you've thought about it, you've talked to your provider, you make a choice, the provider writes a prescription. If it's prednisone, you go to your local pharmacy and pick it up. If it's any of these other drugs right now, you start the prior authorization process. And with that, I'm going to turn it over to Christina Trout.
Excuse us while we play musical chairs. So my part of the talk is going to be looking at the steps from when you make a decision with your physician and clinical team to actually getting the medication. And primarily, I'm going to be focusing on the prior authorization process. And that looks different if you're using a generic like prednisone, which doesn't require a prior authorization, or some of these specialty medications. I'm specifically recommending that you look for guidance about these steroids and how to access these high-cost drugs with your neuromuscular team. Your neuromuscular prescriber and team are very knowledgeable about high-cost medications and how to access them. Typically, these are unbiased opinions about the choices, and we're going to support you in whatever choice that you make. And our goal is to improve the health of you or your child, and to do that without financially burdening your family. There can be some inherent biases in this process, and those come from outside forces to your actual health. Your payer, which is your insurance company or your Medicaid plan, wants to also improve your health, but they want to do that at the least cost possible to the insurance company. As a general rule, generic medications are less expensive than name brand medication. There can also be some biases in this process from the manufacturer. They also have the goal of improving your health, and we've been blessed to have so many more manufacturers entering the space for Duchenne care. However, ultimately, they are there with an idea of profit because they need to have a return on their investment so that they can develop more medications. So there's just some bias there. The other place that we look to for guidance is the FDA label or indication. This is sometimes called the package insert. You will notice that if you look at the prednisone package insert or the FDA label, that it's used for many different medical conditions, but you probably won't even find Duchenne muscular dystrophy listed there. However, deflazacort and vamorolone are specific to Duchenne muscular dystrophy. And on that label, they even have some subpopulation indications that related to age and to how that medication is to be used, so the dosage and administration. And if you use that medication in a different way, it is considered off-label use, and your insurance company will consider that investigational or experimental and are less likely to cover the medication. If you're using a generic prednisone, you will not have an enrollment form that involves a lot of consent and involvement of additional forces or people. The enrollment or start form might also already be familiar to you if you're following the manufacturer and when things come to market. The enrollment start form includes gathering information about your demographics, that's your address, your phone number, how you can be contacted, your insurance information, and prescriber information. In addition to that, this includes a consent form where you are consenting to be contracted by the manufacturer's hub. Rachel's going to describe that hub in more detail, but these are employees hired by the manufacturer to complete benefits investigations, help with billing, shipping, any educational needs, but also for marketing. This marketing can include providing you with information about other drugs that they're working on or developing or that might come to market that are not even related to Duchenne muscular dystrophy. And then the financial information that's on there is that you're asked to include your household, number of people in your household and your household income. So you're revealing information that may not be relevant for your immediate health care, particularly if you don't qualify for the financial assistance. This consent also includes developing a relationship with the manufacturer support staff, which I think can introduce some of that bias. Many of you also then read the fine print where you're consenting to additional information that's being stored, creating a database. You're also consenting to have your information shared with the external specialty pharmacy. Most of these drugs are only available from a single pharmacy, which is a limited distribution specialty pharmacy. So that's the only place that you can get deflazacort and vamorolone, as compared to prednisone, which you can get at any pharmacy. So I just bring these to your attention because I want you to make sure you're reading the fine print and knowing what you're signing up for. You may have already submitted your start form online. If you're working with a neuromuscular team, we encourage you to do that start form with your team so we can talk more detailed about that consent form. Once you have considered what medication you're going to use, there's a benefits investigation or a BI. This is really a review of your medical and pharmacy benefits provided by your payers. There are many different kinds of payers in the United States. They can be commercial or a private insurance company or a government payer. If you have a government payer like Medicaid, Medicare, or military TRICARE, there may be restrictions to using a manufacturer's assistance plan, financial assistance plan, and those will be detailed with whatever team you're working with. After we look at who your payer is, we look at what policy they might have, and one of the terms that you might hear is this on the formulary? Basically, the formulary is a list of medications covered by your payer, often referred to as a preferred drug list. The preferred drug list may also have tiers where tier 1 is something that's easy to get, generic and less expensive. Or tier 2 or tier 3 might be on the list of drugs that require a prior authorization, and there are established criteria for when the insurance payer will or will not cover that medication. If it's not on formulary, don't be too worried at this point. Medications that are new to market often take several months before they are actually on the formulary or list of preferred drugs. In that interim period, sometimes rather than submitting an appeal, we ask for an exception to policy so that you might have access to that medication. In addition to that, we're looking at your payer plan. There might be 5 people lined up in a row with Blue Cross Blue Shield, but each one of them has a different amount for their deductible or copay. For those of you that have very high copayments for your medication plan, a $5,000 per month medication might be very expensive if you're sharing the cost of that with your insurance company and paying 10% of that out of pocket. Some people don't have a payer for their medications, and so there is a separate pathway for low cost or free drugs. Once we're considering the prior authorization, which is sometimes just called a PA or a prior auth, what we're talking about is an approval granted by the payer authorizing payment for that medication. The terms of the prior authorization are established by the payer. Those are not established by your clinic. So it's not that we're trying to tell you, you have to have all these things in order to get this medication. It's established by your payers. The prior authorization request is typically submitted not directly to your insurance company, but to a pharmacy benefits manager or a PBM, which is contracted by your payer. So if you have Blue Cross Blue Shield or United Healthcare, they're contracting with a different group that actually manages this prior authorization process. As I just said, the word process, it is a process. This can take sometimes weeks or months to go through this, especially if the drug is new to market or if there's new competition to think about. The neuromuscular clinic may handle this differently from clinic to clinic. So the prior authorization process can be done by the manufacturer's hub or the neuromuscular team. So you'll want to know who it is that you need to go to for when you have questions about the prior authorization denials or appeals. This is, again, a decision that's made by your neuromuscular clinic. If the hub is the one doing the prior authorization, they have to have access to not only the prescription, but all of your chart notes and the documentation required to meet that prior authorization criteria. The criteria that I'm referring to, established by your insurance, is typically then provided on a form, a prior authorization form. The most typical ones that we see for Emflaza have been that it's required to have an expert providing and prescribing the medication and managing your health care. You have to have a verified diagnosis of Duchenne muscular dystrophy, which can be difficult if you've been previously diagnosed with Becker muscular dystrophy, for example. Some of these medications are only approved for Duchenne. Many of the policies require that you have had a trial and a failure of a lower cost medication before they would consider authorizing this more high cost medication. And then they want to see that you're making improvements. And we know that the natural course of the disease in Duchenne is that of decline, and that the steroids are there to slow that process. So sometimes that can be difficult to document and to convey to the payer. Bottom line, sometimes you need a letter of medical necessity written by your provider and clinic team. Whoever's doing the prior authorization submits the prior authorization form and those documentations showing that you meet this criteria. That's often done on a portal, like an online submission process or a fax. And we typically hear back from the pharmacy benefits manufacturer manager in about 3 to 7 business days. This process can take a long time. So be in contact with whoever's doing the prior authorization if you feel there's been a delay. I want to encourage you to talk with your providers and your pharmacy. If you have any changes in your, excuse me, benefits, including your insurance payers, that starts the prior authorization process completely from the beginning again. Don't be discouraged if you have a denial. It's very common to have a denial for high cost medications when they need more information. That appeal or exception to policy is typically done by the neuromuscular provider and their team. However, it can be done by the hub or the family as long as all of the information is shared. I'm not going to go into the details of why you might get a denial because I think Rachel might touch on that and you can ask questions about it. But you might have multiple layers of the internal appeals, and ultimately it can go to an external review where a third party reviews all of the information that's been submitted and sees if you've been treated fairly and whether or not medical necessity is met and that the insurance company actually should pay for your medication. If you do not have coverage for these high cost medications, there might be a different pathway. Sometimes that's going back to your provider and talking to them, and maybe the generic low cost medication is the best option for you so that you can get started on your medication sooner rather than waiting for these processes to resolve. Other times, if this is the best option for you, you might have a referral to a drug assistance program. Most of the manufacturers for the name brand drug have foundations where they have funding through charitable donations that can help to cover your co-payments, or outside foundations that will pay for the entire cost of the medication. There can be other things like prescription saving coupons like GoodRx, state programs, and non-for-profits that will help to fund part of your medication pathway. So once all of these are approved, you are ready to go to fulfillment through the dispensing pharmacy. As I already said, that this is usually through a limited distribution pharmacy, meaning there is just one pharmacy or a couple of pharmacies that have the rights to fulfill that prescription and deliver the medication. There's many responsibilities for that dispensing pharmacy. I'm listing those on this slide. I'm not going to go into detail about those, but essentially it's processing the claim, verifying payment, and then arranging shipment to you and making sure that you get your refills. As the startup of new medications come to market, there can be some hiccups in this process. And the limited distribution pharmacy may actually be out of network with your payer. And again, it just takes several steps to get all these things lined up. The prior authorization process is a cycle that goes round and round and round. I put whammies in there to show you where there are often troubles along the way. And I won't go into all the details because I think I've touched on many of them, but it's important for you to maintain contact with your neuromuscular clinic, have regular exams to show that we have the documentation that you continue to meet the criteria. And Rachel is going to take it from here to talk about some other communications and how the hub, your neuromuscular clinic, and the pharmacies all interact with each other.
Right, perfect. Thank you, Christina. So Christina did a wonderful job explaining about all of the different roles that are included in this process. I'm a very visual person, so I appreciate a graphic and how these different organizations interact with each other. So you guys as the patients and caregivers are really at the heart of this. And then we have our clinical team to the right. You guys are all familiar with your clinical team. I think the big question mark is that operational team. How exactly do these different parties interact with each other? So you may notice that there's a little bit of a bubble bridge at the bottom of this slide connecting that clinical team to the operational team. So those are two separate entities. And frequently you guys as the patients and caregivers are in the middle of this. So the pharmaceutical manufacturer is the company that physically makes the medication and frequently markets it as well. A hub, which Christina had mentioned earlier, is a third-party entity that is affiliated with the manufacturer. Hubs are newer service lines within the pharmaceutical industry, and they're commonly present for medications, for specialty medications, especially higher cost specialty medications. The overall goal of a hub is to have better and more comprehensive clinical services for patients. Some hubs do better at this than others. But truly, they serve as a single point of contact for manufacturers to follow patients that are on medications and then also gather data. So hubs do have a data reporting component to them. It is important to remember that hub employees are not members of your healthcare team. So they are employed by the manufacturer or through a specific third party. For health insurance, many of you are familiar with this already. So it's just that system and process for decreasing risk and sharing healthcare. So you can have our commercial payers or our state and federal funded insurers such as Medicaid. The pharmacy benefit managers are a little bit more of a gray area. So they are a third-party company that helps to execute prescription drug benefits for insurance companies. So Christina had mentioned earlier the setting of criteria and enforcing of criteria. This is usually the job of the insurance companies that are contracted, or excuse me, usually the job of the PBMs, which are contracted with the insurance. Some examples of these are Express Scripts and CVS Caremark. You'll see these names written on your prior authorization approval and denial letters. Specialty pharmacies are special pharmacies that are licensed and accredited to dispense specialty medications. They may or may not be affiliated with a specific insurance or PBM. Within the pharmacy, if we were to categorize pharmacy, I would put them into three different categories. Our traditional retail, which is our corner drugstore, our Walgreens store down the street, that is that brick and mortar entity. They carry most medications, especially generic medications and oral dosage forms such as pills and liquids. Comparatively, mail order they're physically located at a distance. There may have one or two locations in the entire United States. They carry a similar product line to traditional retail pharmacies, but they may dispense them in larger quantities, and insurance may require you to fill medications at this location. Specialty pharmacies are different in that they only carry certain medications, and frequently those medications are completely different from the medications that are available at your traditional retail and your mail order pharmacies. They are located distantly from you typically, and they may have one or more locations, and so therefore medications are mailed to you. Specialty pharmacies may be required through a manufacturer. I'll talk about that process a little bit later on. Some examples of these are Accredo and Anovo, Accredo is one of the pharmacies that dispense Emflaza, and then Anovo will likely be the pharmacy that will be dispensing vamorolone. Comparatively, your regular prednisone and your enalapril are available at your traditional retail pharmacies. So specialty pharmacy or specialty medications are specific type of medications that are those that are only available through a specialty pharmacy. So there is not a formal definition of specialty pharmacy, but I've included one example of a definition up here from the National Association of Specialty Pharmacies. And so the important thing to remember is that specialty medications are typically used to treat complex, serious, or life-threatening conditions such as Duchenne. And frequently the drugs themselves have special administrations such as injections. They may have significant side effect profiles or require extra monitoring. One of the uniform characteristics are also that specialty medications are almost always very expensive. So this designation as a specialty medication is typically made by a manufacturer. And then sometimes insurance can classify certain medications as specialty medicines, and then rarely the FDA will step in and require a manufacturer to classify it as a specific type of specialty medication. So specialty pharmacy and specialty medications were originally born out of the need for providing extra services to complicated patients, such as HIV patients who are receiving multi-drug regimens, those receiving IV nutrition or special oncology infusions. But this industry has continued to grow and evolve. And so the hallmark for specialty pharmacies these days are that patients who are receiving specialty medications do require just a higher level of clinical care. And so these specialty pharmacies come with additional comprehensive patient care services. So as a patient or a family member, this means that you will be interacting with your specialty pharmacy a little bit more often if you're receiving a specialty medication. So you'll have additional contacts that may be through phone calls, through a web portal, through text messages. When and if you're getting started on a specialty medication, such as deflazacort or vamorolone, the pharmacist at that specialty pharmacy frequently has an intake or history gathering process, including gathering allergies, additional medications, to provide an extra level of clinical review for drug interactions, making sure that it is appropriate for the patient. And then they typically provide an extra level of education as well. So that could be education on side effects of the medications, expectations, how to actually administer and store the medications. And then there will typically be follow-ups as well at different intervals. So to check up on your clinical progress and then also evaluate for concern for side effects. As I mentioned on the last slide, specialty medications do come from specialty pharmacies, and since those are located not in your town, then there's some additional steps to actually obtain the medications, since you can't get them from your local retail pharmacy. And so typically specialty pharmacies require a touch point prior to dispensing the medications. And so they will be calling you or sending you text messages each month or when you're due for a refill of the medication. And then we have sometimes a clinical check-in by a pharmacist or another healthcare member is required prior to dispensing the medication as well. When medications are coming to you via mail, there are some additional shipping logistics as well. So the medication may require a signature upon delivery. It may need to be refrigerated soon after receiving, and so it will be an overnight shipment. We know that there can also be challenges with shipping logistics. So in Iowa, we just had a negative 20-degree day, and so medications weren't able to be shipped out then. So we have to deal with the challenges that these specialty pharmacies located in remote locations bring. And these medications are expensive, and then Christina went through extensively that there's extra insurance steps when choosing a specialty medication, and so that can delay the time to start while all of those pieces fall into place. Since these medications are expensive, there can be an additional cost to you as the patient, but certainly there is an increased cost to insurance and then society or the system as a whole. I think the big question always is, how do I know what pharmacy I need to use or can use? And it depends on many factors. So the first one being the manufacturer of the medication. So a manufacturer can designate a medication as limited distribution. So it's not available through every specialty pharmacy in the United States. It may be only available through a certain pharmacy that they are contracted with. So that is the case with deflazacort and vamorolone. Medications can have additional restrictions imposed by the FDA, such as REMS medications that are only available through accredited REMS pharmacies. That's not applicable for these Duchenne medications. Furthermore, insurance or your pharmacy benefit manager can further restrict your ability to access or utilize a specific specialty pharmacy. So in the case of deflazacort, that's currently available at 3 different specialty pharmacies. Your insurance or PBM may require you to use a specific pharmacy in that instance. So unfortunately, you as the patient and caregiver, your personal preference comes in third in this hierarchy of deciding what pharmacy to use. And that's when we're talking about that category to the right, specifically specialty pharmacy. The benefits of traditional retail is that most insurances and PBMs do not lock patients in, and I say most. So I'm going to change gears a little bit here and talk about brand and generic medications. So brand name medications are those that are sold by a specific company under a trademarked name. Comparatively, generics are non-trademarked drugs, but they have been shown to be therapeutically equivalent to that brand. And so they contain that same generic medication. So example, deflazacort to Emflaza. There are additional subcategories of generics called authorized generics. That is when the same manufacturer as the brand or innovative product actually makes a generic, which I know is a confusing concept. And then branded generics, where a different manufacturer makes the medication, but they sell it under a different brand name. I have listed some examples down below. In order to understand how a generic medication comes to market, which we'll discuss next, I want to make sure everyone understands the pathway for brand names. So initially, a chemical or what will become a drug is studied by a manufacturer research organization, and it's proven to be, and then hopefully it's proven to be safe and efficacious. So that data that the manufacturer or the research organization obtains is then submitted to the FDA review. And then if they designate it as to be clinically needed to show both clinical efficacy and safety, then it is approved. Upon approval, the brand name product will be given a time of exclusivity based on the time they've been studied the patent, or excuse me. So it will be given a period of time of exclusivity where it can only be marketed under the brand name product. This period of exclusivity is different based on the drugs, the indications, and that is determined by the FDA. When that exclusivity period ends, then a generic medication is available to be produced. So in 1984, a law was passed making it actually easier, making the generic drug approval pathway easier. And so this led to the pathway being less time consuming and less costly for generic manufacturers. And that really brought the advent of generic drug manufacturing to the forefront. And so once that exclusivity period ends, then other manufacturers are able to step in to produce generic versions of the medication. These generic manufacturers do have to perform extensive testing to prove that the generic drug is appropriate. So they complete manufacturing, they prove that their manufacturing capabilities are appropriate so they can produce consistent batches of drugs, that the inactive ingredients within the product, so the things that keep the pill together, are safe and they won't cause any harm to the patient. Make sure that the container that the drug is stored in, it does not cause additional degradation or breakdown of the drug. Make sure that the drug itself stays good for the period of time that they indicate within that expiration date window. And then most importantly, they need to prove therapeutic equivalence. So when they have shown all of these and proved this to the FDA, then the FDA will hopefully provide it as a generic. And really the goal of generic drugs is to increase market competition and decrease costs. And the reason why that act was passed in the 80s. So I mentioned that the big important part is therapeutic equivalence. So this is a really dense and technical slide, but I just wanted to make sure you guys had the details. And I'm happy to take additional questions about this as well. So therapeutic equivalence means that the drug shows equal effect and no difference if it's substituted for the brand name. They do this by showing two different things: pharmaceutical equivalence plus bioequivalence. Pharmaceutical equivalence is proven by demonstrating that the compound that is going to be approved as the generic is the same active ingredient. So deflazacort to deflazacort, the identical amount of drug, so that milligram strength, and then it's given via the same route. So for the medications we're discussing, they're all oral. And then bioequivalence is a little bit more complicated. So they need to demonstrate that the generic drug enters the blood over the same length of time and it lasts the same time in the body, and then also reaches the same drug levels in the body. They do this by completing pharmacokinetic studies and complicated statistical analysis, which I won't go into today. But if they are able to show that the data of those two bioequivalent properties are within a 90% confidence interval, then the medication is deemed appropriate and can be a generic medication. So all this to say that there is a lot of research and study that goes into these medications. Honestly, I did not really appreciate all of this until I went to pharmacy school, and it really gave me a greater confidence in taking generic medications myself and explaining it to patients. And so right now, for those of you who are on deflazacort, you are obtaining it from a limited distribution specialty pharmacy. So one of those 3 specific pharmacies that PTC has contracted with. Previously, we may have some patients that, previous to 2017 when it was FDA approved, we may have some patients here who participated in the personal importation program through the FDA with CalCort, or they may have been part of a study or an EAP program. But then we have another change, which is moving forward, which due to the loss of patent exclusivity with brand name Emflaza, is we have the potential to have a generic version on the market. So we have reached another fork in the road or another decision point for patients. So given that there is an FDA-approved medication, the personal importation program is still not allowed. And so we need to look to that commercial drug. And now we will have a brand, the brand Emflaza, as well as generic deflazacort. However, this can mean some changes for you guys as the patients and caregivers. There may be some changes in insurance coverage for deflazacort, and it could be a positive change, actually. So some insurers and PBMs are presently excluding Emflaza from coverage, but when a generic becomes available, the cost is typically decreased. And so insurances could possibly change their coverage of this medication in a positive way. It may mean improved insurance cost sharing or just differences in insurance cost sharing for you guys as the patients. And then there may be changes in the specialty pharmacy or the pharmacy availability in general. And there could be a change in possible hub services that are offered by the manufacturer. So as I mentioned before, the hub services are typically associated with a brand manufacturer. And so those may change or not be available for generic versions of the medication. So when a generic medication is available and deemed therapeutically appropriate by the FDA, a pharmacist can legally substitute out a drug when there is one available. So if you and your healthcare team have decided that a brand name drug is the best option for you, for example, brand name Emflaza, then in order to obtain that medication as a brand, a prescription can be provided with a DAW code, or dispense as written. I've listed several here, but that DAW1 is the important, which means that no substitution is allowed according to providers. Importantly, prescribing and insurance are completely different processes. Just because a provider or even a patient has elected a brand name medication does not necessarily mean that insurance has to cover it, despite them covering a generic version of the medication. And so, in addition, you may have some difference in cost sharings, and every insurance policy is different. And so there's a lot of unknowns in this process. As we move forward, we learn more about generic deflazacort being available. So stay in touch with your insurance company, and most importantly with your care team if you have questions about this. So what I hope you take away from this is that these specialty medications are complex. It takes a lot of work from a lot of different entities, and so it's important to communicate all of the steps, especially to your care team. But I want you to feel comfortable either switching from a brand or to a generic medication, or using a generic medication from the start. These generic medications go through rigorous testing to be approved, and they offer a great option for patients, for society, and insurance. So if you have questions, talk with your care team. So that is the end of our set presentation for today. So we are happy to take questions.
Thank you so much, Rachel, Christina, Dr. Mathews. I know I just learned a ton of really helpful information, and I'm sure that you all at home, at work, wherever you are, have questions as well. So we are happy to work through some of those questions now. You can drop your questions into the chat and we will work through those for the remainder of the hour. If you all want to pull down your slides or keep them up, either way is fine. But I do have a couple of questions that I have that I think can maybe kick us off and are probably relevant not only to loss of exclusivity for Emflaza, but for the approved therapy landscape for Duchenne as a whole. And that first one, and I think this is probably a question for you, Rachel, is what are some of the common reasons that families might choose to stay on brand drug? If I think back to my days in college when I was a pharmacy technician, EpiPens, Synthroid, those were drugs that were very commonly dispensed from my retail pharmacy as brand. Can you talk us through why that might happen?
Yeah, so really that is a choice between the patient, caregiver, and their care team if they want to stay on. However, some patients can be exquisitely sensitive to medication changes. So on that very dense therapeutic equivalent slide, I had talked about how there is that 90% confidence interval. So the drugs need to fall within that window. However, when you change within that window, sometimes patients can see clinical differences, and if they notice clinical differences that can't be otherwise accounted for by adjusting a dose of a medication, that may lead them to want to be on a brand name medication. And so there are no differences in changing within that appropriate window.
Okay, so let's take that a step further. Let's say that I am the mom of a child with Duchenne, and you know what? We're super comfortable because we understand everything that you've taught us about bioequivalence and all of the regulatory requirements. And we're like, you know what? We're good with trying out generic. And we do it. And oh my goodness, we see a difference. We see sensitivity. Maybe this is a question for all three of you. What do I do next if I'm interested in going back on brand? And what are some of the complicating factors that I might anticipate working through with my medical team?
So I would say anytime you start a drug, whether it's a switch in brand to generic or something else, if something bad happens, call your healthcare team. And we do not want that. So if what we would need to do is document what happened. We might ask you to come back in. If you say that, oh, he's, gotten much worse, we might want you to come back in so we can document that. Then we would go back to, say, maybe you are one of those incredibly sensitive people who this is just not going to work for you, and we write a new prescription, but then we have to go back through the prior authorization process and convince the insurance company and everybody else that these guys have just talked about that this was a bad medicine for this child.
And I think that the other key point is that would be a rare thing. We should not be experiencing this over and over again with multiple patients. That having a sensitivity like that is probably a rare occurrence.
Wonderful. Thank you so much. I know that we think about Duchenne as a rare disease, and so our boys are already rare. And I think that this is probably something that is a source of anxiety for a lot of families. And so I think knowing what to expect on both ends of the spectrum is just so helpful. Speaking of the opposite end of the spectrum, so generally, how long would we expect to see a period of patent exclusivity for an approved drug? Obviously, Emflaza to deflazacort, this is the first one that we're seeing in the Duchenne space, but we've got some other drugs that have been on the market for a few years. Is this something that we're going to be seeing more and more of?
Yes, so I had mentioned before, it's dependent on the drug. So a patent for a new drug is good for 20 years. And so that is from the time that they file with the FDA with I want to make sure I have my wording correctly. I believe it's the new drug application, the NDA, from that time. So sometimes clinical trials can last a short period of time. Sometimes they can last numerous years and eat up that period. There are additional exclusivity timeframes that can be added to drugs based on the designations through the FDA. For example, for a rare disease such as Duchenne, manufacturers get an additional exclusivity period. I believe that's 6 months. And then pediatric drugs can also get additional exclusivity periods. And I believe that's another 6 months. And so that's why the time frame is variable.
Perfect. I think that's super helpful. And then the other question that I had, so you talked a lot about the difference between retail pharmacy, mail order pharmacy, and then those specialty pharmacies, which we have been dealing with pretty much exclusively outside of oral prednisone when it comes to Duchenne approved therapies. Are there specialty pharmacies for high cost generics?
Oh, excellent question. Yes. So this is getting back to that relationship between the manufacturer and essentially what they contract and designate. And so it is possible that there are presently generic medications that are only available through generic pharmacies. And so I think that's one of the question marks as we move forward with generic deflazacort. We will all be learning together on how the medication will be available. But yes, generics are available and sometimes required to be obtained through specialty pharmacies.
Can I just make absolutely clear so we aren't all called by our patients saying, I want to switch to generic deflazacort?
Yeah.
It is not available.
Oh.
It is theoretically going to become available, but right now we cannot prescribe generic deflazacort. It doesn't exist.
I think that that is an excellent point. And actually, you kind of teed me up really nicely, Dr. Mathews. So Rachel, I know that we talked about this a couple of weeks ago on our planning call, understanding what has been submitted to the FDA. So we know that the patent expires and that loss of exclusivity is in early February, but we don't know if it will be available in its generic formulation, and if so, what that time frame would look like. Rachel, can you talk to us about the regulatory side and how / if / when we would know that something is potentially coming down the pike?
That is an excellent question. This is still one of the unknowns. So you can tell when the patent exclusivity expires. That's available on the FDA website through something called the Orange Book. So we know that brand name Emflaza, the patent is expiring, or the exclusivity period is ending in February. What I don't know is if there are generic manufacturers that have submitted to produce generic deflazacort yet. All of the information that needs to be submitted, it goes into something called an ANDA, or additional drug application. And so I have not seen any ANDAs that have been submitted, but I don't work at the FDA. So this is just what is publicly available information. So that's a question mark, but I expect we will learn more in February.
That makes perfect sense. And it sounds like perhaps the first place that we might learn of something coming would be through something like an ANDA being filed with the FDA. Is that correct?
Correct.
Awesome. Cool. Okay. This is really helpful. I am learning, like I said, so much. Let me see here. So one of the questions that we received was in regard to previous access to deflazacort outside of the US. So Dr. Mathews, I know you briefly touched on how the families used to access it through that means. Then we got brand, and there was the EAP study and all of these different pieces. So I don't know that there's a clear-cut answer to the question, but it reads, how does the generic compare to the original version that we received from the UK, both in formulation and cost? We know that that cost is a massive question mark. We have no idea. But are you able to speak to different requirements for formulation in Europe and the US?
To the best of my knowledge, what we used to get as Calcort is the same as what we now get as Emflaza. They appear to be identical in terms of side effects and effectiveness. I will say that I know many people who were familiar with that, and Rachel touched on this. It is not, strictly speaking, legal to bring in the European, Canadian, cheaper versions anymore because it is an FDA approved drug. So we can't do that anymore. But I presume that the previous Calcort, generic deflazacort, and Emflaza will be the same.
And I'll add that there's no regulatory requirements for formulations to be exactly the same between governmental agencies. So example, the EMA or the European version of our FDA. And so I think that question is an unknown. I'll also add that certain organizations have requirements for those inactive ingredients. There are certain compounds in Europe that are not able to be used in the US. I do not know if those were used with Calcort or not. And so if there is a difference, but there's a potential small difference within the inactive ingredients within the product.
Excellent. I think that that's probably a big question that a lot of the community has, who's been around for a long time, and has kind of ridden this wave of different means of access. So that's incredibly helpful. I think that actually covers a lot of the main topics that we're seeing in the questions that have been submitted. I do have one question that I think is helpful to just kind of reiterate. So Christina, you talked a lot about prior authorization for these brand drugs, for some of these high cost drugs. Would a prior auth necessarily be required for something like prednisolone or prednisone?
Typically, it's not. Typically, the prior authorization process is utilized to reduce costs to the insurance company. So they want to make sure that you're using a drug that's beneficial for you and at the least amount of cost to the insurance company. So we've not ever had to do a prior authorization for prednisone or prednisolone. It is, when you do that, you literally are getting a prescription from your provider and picking it up at the pharmacy. So there's none of that middleman process.
Absolutely. I think that's really helpful. And perhaps if you're a newly diagnosed family entering this whole conversation for the first time, it could be really overwhelming and confusing to understand, some of the differences and implications across these different drugs. Well, we are nearly at the end of the hour, and University of Iowa team. Oh, go ahead, Christina.
Can I say something about the prior authorization? So we're talking about a very lengthy process, but at the same time, it's not an emergency. You're not bleeding from a wound. So it is something that you want handled in a timely manner. But the process does take sometimes a few weeks or even more than a few weeks, a couple months, depending on where you are in your disease process. That's not an emergency. For someone else who might be plateauing and needing to get this done right away, like a newly diagnosed, you talk with your provider about the urgency, and that will help determine what pathway you should go to.
I think that's really helpful advice, Christina. And it really reflects nicely upon, I think, our conversation as a whole, which is as you're making these decisions for what's right for you or for your child, if you're thinking about starting steroids, switching steroids, talk to your medical team, lean on your neuromuscular team, because they are the experts and they can work with you closely to figure out which drug, which regimen is most appropriate in your specific circumstance, because what's right for one individual might not be what's right for the other. So with that, I think we are going to go ahead and start to wrap. I want to remind everyone that we do have other steroid resources, including a couple of different webinars specific to vamorolone or Gamry available in our archives, which we will link for everyone with our recap. We will have that recap blog and recording link available early next week with some additional follow-up information if you want to share this recording with other family members, caregivers, etc., or if you want to go back and rewatch as a resource. I also want to mention the PJ Nicholaff steroid protocol. If you have questions about steroids and how they affect your adrenal glands and your adrenal suppression, that's a really great resource. That also talks through stress dosing. And a lot of that now remains a little bit unclear with the changing landscape, but is a really great place to start. And if you have additional questions, we welcome those. You can send us emails to careteam@parentprojectmd.org, and we'll be happy to work with you directly to answer any specific questions. With that, I want to thank our team at University of Iowa, Christina, Rachel, Dr. Mathews for joining us, and thanks everybody for tuning in. We appreciate you, and we hope you have a great rest of the day. That concludes today's webinar.